Welcome, everyone, and thank you for joining today's webinar on PHTI's assessment findings on virtual solutions for depression and anxiety. My name is Jared Augenstein. I'm a Senior Managing Director with Manat Health, and I'll be moderating the Q&A. For now, I'm delighted to welcome Caroline Pearson, Executive Director of the Peterson Health Technology Institute.
Thank you to everybody for joining us on our webinar today. I am so pleased to share with you results from our fourth digital health assessment. And if we go to the next slide, I will just remind folks who may be new to PHTI, we are an independent nonprofit that conducts independent assessments of digital health solutions with a specific focus on clinical effectiveness and budget impact. Today, I'm going to talk you through the results of our report that was released yesterday, examining virtual solutions for depression and anxiety. And you can go to our website. This report, as well as supporting materials, including short guides for patients and policymakers, is all available at phti.org, as are all of the publications and past assessments that we complete. This work is challenging. Generally, it takes us about 7 months to complete each assessment. And so I really appreciate everybody joining us today to dive into more of the details about what we found and how we do this work. And I look forward to taking your questions at the end of the conversation. If we go to the next slide, I'll tell you a little bit about our process. We are really focused on how to drive forward better adoption of high-value digital health tools and health technologies. And so we really are thinking specifically about choosing topics that have a high burden of disease and drive significant healthcare spending. We then look at areas that have significant digital health investment, where solutions are coming onto the market, we've got good competition and enough time and space that we've got really robust evidence with which to assess these solutions. And our goal is really to inform decision makers. First and foremost, that is purchasers, whether that be health plans, employers, or health systems that are making decisions about which digital health solutions they're going to bring on and pay for their members. But it is also for investors as well as digital health developers who are constantly trying to advance more cost-effective and clinically effective tools in the space. Our assessments really seek to answer three main questions. Do the solutions work? For whom? Meaning for which patient subpopulations are they going to be most impactful? And then, are they worth it? And in the question of are they worth it, we really take a look at total healthcare system costs from the view of payers. So looking specifically at commercial, Medicare, and Medicaid payers to understand both how solutions may reduce future healthcare spending and also whether those savings offset the prices of the solutions as they exist today. From there, we attempt to synthesize what is many months of hard work into very clear recommendations to guide the market on which solutions warrant broader adoption, both by purchasers and in turn by providers and patients, which areas need further evidence generation, or in this case, additional price negotiation, and in some cases where we do not see enough evidence that supports broader adoption. And we make that clear to the market. We also have a very broad stakeholder process to help us do this work. We have a purchaser advisory council with about 40 employers, health plans, and providers that give us input about which areas of solutions they are considering in the next 12 to 18 months that would be worthy of us assessing. They help us understand how they think about decision making and what kinds of information would be helpful to inform their process. We also have a digital health collaborative, which includes leading industry and patient groups, each of whom are committed to improving evidence generation in support of high-value health technology. And they come together to share feedback and to provide input on our process, as well as to explain to one another what they are each doing to advance this area and this field. Once we go into our report process, we have a much tighter method for stakeholder engagement, as everybody that is involved in our reports has to be cleared of any conflicts. We conduct a systematic literature review with wonderful HEOR partners who are well-versed in structuring and reviewing each of the pieces of literature. We also work with health economists to create a budget impact model to estimate total costs and potential savings. And we work with digital health companies that are included in the assessment and have the opportunity to submit evidence, commercial data, and additional market information to help us really understand the value that they're bringing to the market and make sure that our assessments are well informed. For each of our reports, we recruit clinical advisors, and you can see them their names included in the PDF. They help us understand how usual care is administered today, and how some of these digital health solutions would integrate into existing workflows. And we work directly with patients to really understand what their priorities are, what metrics matter most to them, and how they experience digital health solutions in their own lives. So with that, let's dive into this most recent report, really focusing on anxiety and depression for people with mild to moderate symptoms. If we go to the next slide, and again, we can see on the next slide that we all recognize and know somebody who has struggled at one time or another with mental health conditions, particularly with depression and anxiety. And unfortunately, many of those folks struggle to gain access to care. We have probably experienced that many providers or therapists have long wait lists. They may not be taking new patients, or they may not be included in insurance provider networks. So with more than 1 in 5 adults suffering from symptoms of anxiety and depression at any given time, it can be a real challenge to meet the healthcare needs of this population, and too many people go untreated and unfortunately suffer the consequences, which can include significant impacts on their daily life, as well as implications for healthcare spending. You see on the right-hand side some of the economic data that is going to feed into our discussion on the budget impact model. But there is a significant difference in healthcare costs for people with no or mild symptoms of depression and anxiety versus those with more severe conditions. And you see for depression, we've got over a $4,000 spread in that annual spending. On the people with anxiety, about a $3,000 annual spread. And what that means is that if we can help patients improve their symptoms and sustain lower levels of anxiety and depression, not only is that good for their lives, but there is a potential to reduce healthcare spending, both for mental health treatment, but also for other conditions, as we know that anxiety and depression can exacerbate other comorbidities for patients. So as we began to think about doing the assessment in this space, one of the things that we focused on is what are patients looking for? And for too long, I think we have considered the best in class mental health care really to be an in-person talk therapy based engagement between a provider and a patient. Not only is that challenging to scale given the workforce constraints that we have, but it can also be very challenging for patients who either may suffer from social stigma or may simply struggle from an access and convenience point of view to get in to see a therapist on a regular basis. You see this patient quote in the lower left-hand side of the slide that describes how a virtual solution creates more accessibility because the timing is convenient, there's no transportation involved, and we heard time and time again from patients that it is very important to them to have a variety of treatment modalities available at the times and place that are going to be most convenient to them. And I think that's really what you're going to see when we go to the next slide as we speak to what these solutions have been designed to execute against. So what are we really looking at in this report? First and foremost, all of the virtual solutions in this report are building on a backbone of digital content that is based in CBT methods. So these are libraries of videos, guided lessons, and other activities that people can access on demand whenever they are inclined to use the solution, and they can find different topics and different exercises that meet their needs. Then the solutions in our report really combine and layer in different components of care on top of that digital content backbone. Many of the solutions begin with conducting assessments to understand people's current symptoms and help guide them to the appropriate level of care. They also can include various approaches to coaching and other methods to maintain engagement. So encouraging people to continue to use the solutions, to stick with their treatment, and in some cases, guiding them towards different modules or video content that might be most useful to them. And then for a subset of the solutions in this report, they also integrate virtual networks of additional providers who can offer therapy as well as, in some cases, prescriptions for medications when needed. So let's look at how these stack together on the next slide. In our report, we examined 15 different companies that were offering mental health solutions. And then we grouped them into 3 broad categories. And we assess companies and solutions in categories for several reasons. First, we find that it is helpful for purchasers to understand what the different approaches are in the market and how one company versus another compares in terms of their sort of broad sales strategy and what the intervention looks like. We also find that because many of these solutions are not going through the FDA, it is helpful to look at a broader body of evidence across similarly situated solutions to understand really what the clinical effect of any given intervention is going to be. Virtual talk therapy offered by multiple different providers may have many studies, and we want to look across the body of those studies to get confidence in the outcomes. So you'll see here that we have 3 main categories in this report. The first are really self-guided solutions. And these are solutions that begin with an initial assessment on symptoms. They then really are offering that digital library of content. And some of them include coaching and other engagement mechanisms. They are often being sold to health plans or to employers directly. And in some cases, they may be a substitute for employers' existing employee assistance programs, or EAPs. You'll notice that there are a few companies in this list that have asterisks next to them, and that's because they appear in 2 categories. So those companies offer blended care solutions, but they also offer more of the digital-only solutions for some purchasers. The second category is prescription digital therapeutics. And these are relatively a new category that is FDA-cleared devices that, from a patient experience point of view, are quite similar to self-guided solutions in that they're offering, again, these libraries of digital content and activities. But the way that they plug into the health system is somewhat different because these are need to be prescribed by healthcare providers, whether that be therapists or other clinicians. And therefore, they are inherently more integrated into other mental health treatment. So a therapist might prescribe a digital therapeutic to a patient and encourage them to perform some of the exercises between therapy visits. And so this is really kind of layering on top of some of that other mental health care. And then the blended care solutions, again, all include some self-guided digital components, but then they integrate networks of providers, whether that be licensed therapists, coaches, psychologists, and psychiatrists that can deliver additional therapy. Sometimes that's going to be live one-on-one virtual therapy. But it can also include other asynchronous methods, including text-based therapy or asynchronous video therapy. And so there's a lot of different ways that those interventions are configured. And again, you see the list here of the companies in those categories. I will note that from a market share point of view, The blended care solutions is really where we see most of the market right now and a lot of the employer and health plan interest. And so we'll talk specifically about both those results and the economics in a little bit. If we go to the next slide, I want to take a step back and talk about how we do the clinical assessment. So with each of our assessments, we generally pick 10 to 12 outcomes across both clinical outcomes, user experience, and health equity topics. But we take care to select primary outcomes that are going to be the most impactful for the clinical condition that we are assessing. And we do that with input from the literature as well as from the clinical advisors with whom we work. So for this report, we had two primary clinical outcomes. We were looking for measurable improvements in depression symptoms and anxiety symptoms as measured by validated self-reported symptom scales, including the PHQ-9 for depression and the GAD-7 for anxiety. The other important thing that we do is really try to understand what is a clinically meaningful improvement in symptoms. So often in the literature, we can see statistically significant differences between groups, but they may represent very small differences in outcomes that do not necessarily translate into changes in the way a patient experiences their symptoms on a day-to-day basis, what their care plan looks like, or what their long-term clinical prognosis would be. And so we spend time, again, asking what is a clinically meaningful improvement in any of these outcomes. In the case of depression and anxiety, we do have good literature to support the idea that within the PHQ-9, a 5-point reduction from baseline score to follow-up score is clinically meaningful and would be experienced by a patient. The GAD-7, which is a shorter assessment with a lower total point score, has a 4-point reduction in order to be clinically meaningful. And to give you a sense of those scales, that really is enough to move someone from sort of a moderate depression or anxiety symptom level into a mild and really has a meaningful impact on both their care needs and their spending, as you'll start to see. We also look at other important secondary outcomes here, including psychosocial functioning, which has a range of different metrics and scales associated with it. Workplace productivity, which is very important in the case of anxiety and depression because it is a frequent cause of absenteeism or just lower productivity on the job at work. Adverse events and crisis events, which can include suicide in this case. And then looking at user experience and health equity, metrics of user engagement, of patient satisfaction and usability with the solutions. And then on health equity, we're looking not only at how the solutions are performing across diverse groups of users, but also how they're being distributed in practice to different user groups, whether that be geography, payer type, or other variables. So in doing this report, I am pleased to say that this was the largest and most robust body of evidence that we have seen in any of the 4 reports that PHTI has done. We reviewed over 5,000 articles and other pieces of evidence speaking to digital and virtual care for anxiety and depression. We narrowed that down based on structured inclusion criteria to 103 studies that form the core basis of our findings. And those include a mix of randomized controlled trials and other comparative study designs. It includes real-world evidence. And as I mentioned, it includes a wide variety of company-submitted data on both clinical and economic performance. If we go to the next slide, I want to begin to walk you through our clinical outcomes for each of the categories that we assessed, and we'll walk through that slowly. And when we look at findings for self-guided solutions, I think, again, keep in mind that this is largely thinking about the role that digital content can have in treating mental health symptoms. And I think this is one of the most exciting findings that we saw in this report, because unlike traditional one-on-one therapy modalities, what we found is that digital treatment and self-guided treatment for mild to moderate anxiety and depression is very clinically effective and can be on par with talk therapy. And that's great news as a society where we have access constraints, we have a lot of unmet need, and we need to think about solutions that potentially scale broader access to treatment in new, efficient, and in some case more favorable ways for certain users. So this was a very exciting result, and let me break it down for you a little bit more specifically. Sometimes on these webinars, I like to go through complicated graphs. So if you'll indulge me, we're going to do a little bit of a walkthrough on what you're seeing here. So let's start on the left-hand side with our graph on depression. Our axis is showing you scores on the PHQ-9. And let's just first look at sort of the blue funnel here, which is people who are not receiving psychotherapy. So these are going to be individuals who generally are not receiving other treatment for their mental health care. They're starting on average with depression scores that are at the very high end of the moderate range, or bleeding into sort of moderate to severe range. And I think one of the things that hopefully people have learned from us is that comparative data is incredibly important in all of this work. And so this really gives you a sense of sort of how people perform in the control arm versus an intervention arm. So your dotted line shows you how the various control arms of all the studies in this report changed over time. And what you see is that people do experience, people self-resolve, symptoms self-resolve to some extent for people with mild to moderate depression over time. And so you see that line does go down by a few points. In fact, it goes down by almost 4 points. People using digital solutions who were not otherwise receiving therapy, however, see a 7-point improvement from baseline in their PHQ-9 scores. And what that does is that it means in almost all studies, a population that was not seeing a clinically meaningful improvement in the control group does clear that 5-point threshold that we laid out of a clinically meaningful improvement for their PHQ-9 scores. And that's a really important benefit. And it's one that, again, you see a similar pattern for with the blue section on the anxiety scale. So on the anxiety side, we see that digital solutions improve PHQ-9 scores by 4.6 points on average. And that is 2.1 points more than controls. And again, increases the proportion of studies where you're seeing people hitting that threshold of clinically meaningful benefit. Then we look at people who are receiving usual care. So these are folks that are going to be having a mix of medication treatment or psychotherapy and are sort of regularly seeing a clinician for their mental health care. And there we see that the added benefits of self-guided solutions for people who are already receiving other mental health care are more muted. In this case, we saw that scores improved by 4.6 points over baseline for depression. That's 2.2 points more than the controls, but at 4.6 points of improvement, it doesn't hit that 5-point threshold that we had for our depression improvement. Now, we did see that the depression benefits are a bit more pronounced for people that are starting with more severe depression, and that is common. But again, generally the conclusion here is that these solutions are very effective options for people who aren't otherwise receiving mental health care. But if we're adding them to other sources of care, they're adding only marginal additional benefit. So let's go on and look at the PDTs on the next slide. So again, if you remember, the PDTs are a similar user interface to what the self-guided solutions are, but they are integrated into treatment in somewhat different ways. And importantly, because the prescription digital therapeutics have gone through FDA clearance, this is a space where we saw stronger clinical evidence in support of these outcomes. We had 3 well-designed comparative studies that were specific to the solutions and products in this space, which include Daylight RX, which was approved in September of last year, and Rejoin, which was approved in March of last year. And for each of them, we see clinically meaningful improvements in depression scores and anxiety scores. You see the 5.9 points and 5.6 points. And that is better than the performance that we saw of the self-guided content against usual care. Now, one of the things that I think is important here is that as digital therapeutics are being integrated into treatment, the benefit of having a clinician to be able to suggest suggest which modules to do and really keep people engaged is showing that even for people in treatment, adding a prescription digital therapeutic is delivering incremental additional value in terms of helping those people have stronger clinical benefits. We're going to talk a little bit about the financials on these in a bit, but I will say, this is really promising clinical outcomes for what is a new field. These are some of the first prescription digital therapeutics that we've seen approved, and they are just beginning to be reimbursed in Medicare. And so we were very excited to see these positive clinical results. Next slide. So moving to the blended care solutions, and remember that I told you this is where the bulk of the market is in terms of the purchaser interest, particularly from large self-insured employers. Now, I do want to take a step back and say we've already discussed that there is good clinical evidence around the idea that digital content is effective for people who are not otherwise receiving treatment. And we have a wide body of evidence outside of this assessment that says that talk therapy can be clinically effective, equally or more clinically effective when it's delivered virtually compared to when it is delivered in person. So in some sense, these solutions are combining 2 validated and demonstrated to be effective tools into a product offering that has lots of different levels of care for different patients' needs. However, when we look at the company-specific data, we did not see as robust information in this category about these specific solutions and the ways in which they are integrating their different components of treatment into a single offering. So this category had a lot of single-arm studies and many fewer comparative studies, and that can make it hard to understand what the incremental treatment benefit is of any given intervention relative to control. So what we've done on this slide is to try to sort of simulate what a comparative study design might have looked like. So all of the yellow bars here give you a sense of what the weighted average improvements in depression and anxiety scores were for the blended care solutions. And then we've lined that up against the results that we showed you on the previous slides about the clinical improvements that the self-guided solutions were delivering versus the control arms in their comparative studies. Because again, we do know that many patients experience some improvement in symptoms over time. And so we need to be looking at the benefit of any intervention above and beyond a control group improvement. And what you see here is that these results look very promising. So we see that blended care solutions are delivering stronger clinical benefits on both depression and anxiety, both for people receiving usual care and for people not receiving psychotherapy in depression and anxiety. And each of those improvements exceed our thresholds for minimum the minimum clinically important difference, or to say that these really are differences that matter. So again, that's going to be a 5-point threshold for depression and a 4-point threshold for anxiety. They also appear to be delivering superior clinical results compared to the self-guided solutions. So by having therapists integrated and being able to offer therapy as part of their solution, we're seeing better symptom improvement relative to the self-guided solutions. And so that is a very optimistic finding. I'll also highlight that we were particularly impressed to see the strong clinical benefits on anxiety. Across the other category, we saw more muted benefits on anxiety than we did on depression. So it was good to see these really large reductions in symptoms for people with anxiety using blended care solutions. So this is really an opportunity both to think about how blended care solutions can offer users a range of treatment options. But we would, of course, call for better information and more high-quality evidence about really how these solutions are delivering relative to controls. One important observation here that I'd like to highlight is to really talk about engagement. So what you hear from all of our clinical findings is actually that each of these solutions were clinically effective for specific users. And one of the most important issues for mental health care is really thinking about what are the solutions that we can get someone to engage with. Because in fact, we've got a range of effective treatment options. And so it is really about having variety available and matching users to the treatment option that they are going to be most likely to be willing to try and be willing to stick with. And we do see evidence that the blended care solutions tend to have higher engagement among employees relative to the self-guided solutions, not only because, of course, there's humans in the mix to help drive some of that ongoing engagement, but even in terms of initial participation, there is a sense that workers are more interested in trying these solutions when they know that they've got a comprehensive set of options that includes therapists if that's something that they need. We thought hard and long about engagement throughout this report, and it is an area that requires some further attention. We saw that clinical results across users were quite effective. So the benefits for symptoms were effective across ages, across genders, and across racial and ethnic groups. So these tools work for everybody. However, we did not see equal and diverse participation in real-world studies. So when we look at real-world studies, we tend to see that young white women are much more likely to use virtual solutions than other demographic groups. And we would call on the field to really think about ways to improve outreach and engagement to a wider variety of users, given the strong clinical effectiveness that we saw across all groups. So on that very positive note about the potential of these solutions to deliver results, let's look at the numbers and go on to the budget. So in building our budget models, we work to think about how clinical improvements that we see in the literature will result in additional savings or changes in healthcare spending for individuals. And as I showed you in that first slide with the bar chart, people with lower symptoms of anxiety and depression also experience lower healthcare spending. And so as we see these clinically meaningful reductions in symptoms, that translates to potential health savings. So what you're seeing on this slide is really just like the gross expected healthcare savings that an individual might experience as a result of improved symptoms. So for instance, if we look at the self-guided solutions across a population of people who are not previously receiving psychotherapy, there's about $750 in lower healthcare costs that we would project as a result of their improvement in both anxiety and depression symptoms. And that gives us potential to say not only are these solutions effective, but they can reduce spending over time. Now, of course, we can't look at savings in a vacuum. We always need to offset the actual cost of the solution. And so what you see here are the estimated solution prices for each of these categories that we used in our model. Importantly, I will point out that every company and every company's clients may have different negotiated prices, and so pricing will vary. But this gives you a sense of what common cost levels are for each of these categories and what was used in our budget model estimation. So for self-guided solutions, these are generally being sold at relatively low prices for about $2 per member per month or per employee per month when being sold to self-insured employers. The prescription digital therapeutics, which I mentioned, are newly approved and have new payment codes but reimbursement has not been set formally in the Medicare market yet. We are estimating that those solutions will be reimbursed at about $200 for the device supply. And then there's another $80 in treatment management codes that get billed alongside of that. But we also ran some simulations for prices anywhere from $200 to $400, and I can talk you through that in a moment. And then lastly is the blended care solutions. And these are generally being priced around $6 per member per month or per employee per month, plus additional charges on a fee-for-service basis for people who actually receive therapy. So if we go to the next slide, when we put this all together into our model, what we find is that in the commercial market, which is where these solutions are most commonly being sold today, the self-guided solutions can reduce total healthcare costs on the order of about 30 cents per member per month, which is about $3.6 million for a 1 million member population. The digital therapeutics have even greater savings potential of about 72 cents per member per month for the commercial population at $200 in device reimbursement. Even at $400 in device reimbursement, those solutions do reduce spending in the commercial market. And by our model in Medicare, the break-even point would be about $270 for device reimbursement for the prescription digital therapeutics. So let's talk about the blended care solutions. These are the solutions that I mentioned are generally charging around $6 per employee per month or per member per month as a sort of starting access fee with fee-for-service charges for therapy thereafter. That is a relatively high access fee across users and non-users alike. And so while these solutions produce the highest level of potential health savings, because they are the most clinically effective of the three that we looked at, when you're charging for all employees, including people who may not have any mental health symptoms or may not engage with the solution, these solutions do, on average, increase net healthcare costs for payers in the commercial market. And so that's something that we really need to think about as we are trying to expand access to mental health care, but needing to do so in ways that are sustainable and economically pragmatic. So let's go to the next slide and look at our recommendations. In sum, as you see, all three of these solution categories were deemed clinically effective. Self-guided solutions and prescription digital therapeutics were both cost savings, and therefore each of them warrants broader adoption, particularly self-guided solutions as an access, a way to improve access for people not receiving treatment, and prescription digital therapeutics as an adjunct to other mental health care. The blended care solutions have strong clinically meaningful improvements across both people with receiving therapy and those that are not receiving other mental health treatment previously. But at the current pricing levels and pricing models, they increase spending. And so in order to support broader adoption, we would want to see those prices come down, particularly in that employer and commercial market. On the next slide, we have a few recommendations coming out of this report. So first is the one that you're going to hear from me all the time, which is we want to continue to drive better evidence generation. I told you that this is one of the categories that had some of the strongest evidence that we have seen. But it is not without flaws. Many of the studies were about 6 to 12 weeks in length, and we saw very few studies that tracked people's, whether the symptom improvements were sustained over the long term. And so we'd like to see more evidence around the durability of those outcomes. We also would be interested to see more evidence on patients with mild starting symptoms, given that as we expand and broaden access for for a wide body of users, you may see more people with mild symptoms adopting the solutions, and the clinical benefits for that group may be somewhat more muted. As I mentioned, we would want to see a real focus on ways to drive better engagement across a diverse set of users, including men, including low-income individuals and Medicaid populations, and including people of color. We'd like to see new ways to think about how to use the effective results of the digital solutions to scale access in ways that are really efficient. And so I think there are many ways for us to think about this. For instance, in prescription digital therapeutics, it may be that some therapy providers could reduce the frequency of their visits. Maybe you go from weekly visits to every other week visit. Having patients participate and use the prescription digital therapeutic between visits. Or can we see primary care providers who are often writing prescriptions for medications, but not giving any talk therapy, recommending and prescribing digital therapeutics for their patients, again, as a way to scale access to broader populations. And then finally, and very importantly, looking at the blended care solutions, as we mentioned, there's a real opportunity for employers to negotiate lower per member per month prices, or to think about pricing models that are tied more tightly to engaged users, where we know that there is a lot of economic value to be had. We would also urge employers and solution vendors to think about thoughtful triaging of patients based on their clinical needs. Not every user is going to need or want talk therapy. And if we use clinically effective digital solutions and the availability of talk therapy to step patients up to therapy at the points that they need it, and then after an episode of care to help people use digital solutions as a way to sustain their symptom improvement, that is likely to be the highest value outcome. And then really thinking about ways to increase engagement among workers, and potentially considering productivity benefits, which we believe exist and are measured in our study, but weren't expressly included in our budget model. So let's go to the next slide, and I will briefly tell you what is next for PHTI. On the next slide, you can see the 4 topics that we have already assessed, including diabetes, MSK, hypertension, and now mental health. Our next report is going to focus on virtual care for opioid use disorder, and we'll be announcing soon our additional assessments for the rest of 2025 and early 2026. And so with that, I'm going to invite Jared to join me again, and I'm happy to take some questions with our remaining time.
Great. Thanks, Caroline. So reminder to everyone, you can submit your questions through the Q&A function. There are a bunch in there already, and so we'll sort of dig in. So the first question, Caroline, combining a few, is sort of to discuss how you approach the clinical improvements, measurement of clinical improvements in this assessment. in an area like anxiety, depression. How did you decide? You mentioned when you were reviewing the clinical results that the PHQ-9 and the GAD-7 were sort of the primary clinical measures, if you will. How did you land on those, and how did you consider other measures of clinical improvement in the evaluation?
Well, we look at, as I said, we had 103 studies that were included, and we generally look at all of the outcomes across all those studies. And for anyone who really wants to geek out, there are appendices and data supplements on our website. You can dig into every result from every study. But I think when you look at the field, actually, the PHQ-9 and the GAD-7 are validated tools that are widely used, both by solution providers, but also and researchers, but also clinicians to actually understand the current state of a patient, and then to be monitoring progress over the course of their treatment. And so, this was one where there was pretty good consensus that is generally what folks are using, and it's a widely accepted tool.
And how did the sort of selection of those instruments sort of tie to the budget impact model?
So, as we laid out in the slides, there's a pretty good read through between sort of PHQ-9 and GAD-7 scores and folks' healthcare spending. And so there was a strong connection in the literature base. There are a number of other metrics that different studies used and we looked at. They generally substantiated the findings, but almost all of the studies that we reviewed, at least are including some results from GAD-7 or PHQ-9.
Got it. Okay, we have a bunch of questions coming in related to why you decided to evaluate depression and anxiety in the same report. And just so comment on that, and also some questions about, other mental health conditions and also more severe forms of depression and anxiety.
So, the decision on whether to evaluate them together or apart was one that we thought carefully about. And for instance, NICE in Europe has chosen to look at them individually because, of course, clinically they are different, different diseases that require different interventions. The reality is that we have a significant amount of patients that present with symptoms of both. And so, there's a lot of crossover between those populations. And then further, these solutions are treating patients, some of whom have never been diagnosed, right? They have not been to a clinician or taken a PHQ-9 before. And so, they are sort of presenting with either or both sets of symptoms, and the solutions are, receiving them and treating them across both. And so it was really important to look at it holistically because both the population and the intervention is really a mix of anxiety and depression. I think to your question on severity, we really were focused largely on evidence that was looking at sort of moderate or mild to moderate disease. And these are the people that are working, are caregiving, are outliving full lives and looking to some of these solutions for support for their symptoms. Obviously, we have many more severe mental health conditions in the country that warrant, important focused treatment. And but most of these solutions are generally looking at a sort of more mild or moderate population. So that's really where we're paying attention here.
How did you incorporate patient perspectives when you were analyzing the clinical impact and the cost benefits? As you noted, mental health is sort of a growing concern for much of the country today.
We always include patient perspectives. We always conduct direct primary research with patients. It's actually the only primary research we do is patient research. But we did want to take care to do an extra good job on this report, given just how sensitive it was. So we increased the number of patient interviews, one-on-one patient interviews that we did a lot for this report. I think we ended up with 17 in-depth interviews in total. And we spread them out at different parts throughout our process. So we did a set at the beginning as we were really like scoping, selecting outcomes and thinking about the structure of the assessment, and then did a second set as the results were coming together to really sort of understand how those findings reflected the experience of the patients, many of whom have used virtual care solutions in the past. So it was important. We also had two wonderful research partners, and we used two different partners because we wanted to make sure we got patients with a pretty wide variety of experiences and backgrounds.
Sort of related to that, over the course of developing this report, there's been a lot of public dialogue around sort of patient-facing AI chatbots. And I wonder if sort of that came up in your research and any sort of, commentary on how those tools were considered.
It's one of the most common questions that I've gotten on this report. And when we started, there was unfortunately very little evidence available about the efficacy of chatbots. A very large study came out of Dartmouth, and I urge folks to look at that during our review. Our assessment is that chatbots appear very promising. Either as standalone or as complements to other mental health care. And as we said, I mean, I think the interesting thing about this report is that you see that a lot of different treatment modalities, much more broadly than we have historically understood, can be effective. And so I think chatbots hold a lot of promise, and I would be eager to see more clinical evidence about their efficacy as the market matures.
But another sort of set of market-related questions. So the report, as you went through, had green lights, if you will, for the self-guided solutions. But we're seeing a lot of the purchasing behavior in the blended solutions. And so I wonder if you could talk a little bit about sort of what's it going to take to have clinical and financial sort of support for the blended solutions, which seem to be doing well in the market.
Yeah, I mean, I think the outcomes from the blended care solutions are so strong, and the notion that you can have a more comprehensive set of treatment options available, I think, is very compelling to employers. So, that is very much where we hear our employer partners saying that they are focused. And so I think that's where we need to continue to generate evidence and to generate competition in the market. And so, folks are right to focus there. There's a few things. One, many employers are paying for EAPs right now, generally about $2 per member per month. And so if you can swap that out, that can sort of help offset some of the cost impact of these tools. But generally at about $4 per member per month, as a starting point is when we think these solutions begin to break even. So, that's within range. And I think now that you've got clarity on the value of these tools, we can hopefully see some more adoption and price competition in that space.
You mentioned you reviewed a tremendous amount of evidence for this report, I think more than for any of the previous reports. In reviewing that, were there any gaps? Were there certain populations that you felt were underrepresented in terms of the clinical evidence base?
Well, I think, I mentioned sort of the young white women phenomenon, and that it is one thing to say that the adoption of tools is uneven. That's something that we see regularly. We have not seen so much bias in actual clinical evidence historically. And so it was, strange to see studies that were just predominantly female. I think, and then I said, like, the studies that do have more balanced populations perform well across those populations. So I don't think it's a function of efficacy. I think it's a function of engagement. And, we need to say, like, what is the engagement mechanism that's going to get men to decide to take their mental health care seriously and to pursue some sort of treatment intervention?
Mhm. And so sort of related to that, there's some questions around patient engagement, and what did you learn about patient engagement in the context of these tools? And what are some of the sort of important features when it comes to actually engaging with the digital technologies?
So this is a space where I think more evidence is warranted, because I think we heard a lot from the market, we got a little bit in the evidence. In some sense, the best mental health care is going to be the mental health care you can get somebody to do. And so, more than other categories that we looked at, engagement is a huge component of the final final performance of these solutions. And I think that having comprehensive options is important. So we assumed in our budget model nearly double the rate of engagement for blended solutions as self-guided, based on what we see from the market. And that suggests that comprehensive solutions that give people the confidence that they're going to be able to get whatever they need is important. But we've got a long way to go in terms of really recruiting people to participate in any given solution.
Mhm. All right, so we're getting close to the top of the hour. We have time for one last question. So stepping back a little bit. So as you noted, this is PHTI's fourth report. What impact do you see the work having in the market, and how do you see the dialogue changing given the sort of information that you're bringing into the purchasing space?
Well, we have been so heartened and grateful for the really warm and welcome reception that we've gotten from all the purchasers. I mean, whether it's health plans or employers, they've said, this is information that we need. You're helping us make better decisions. Thank you. And that is, why we do the work. But more broadly across the industry, I am just hearing much more serious evidence-based conversations about clinical outcomes. No one is talking about